Okay, MRI for rectal cancer, it should be a must. In some center where you have reliable ultrasonographer, you could add that one. But ultrasound is operator dependent, especially for T3 disease. So we rely on MRI.
Thank you, Abdullah, for this nice presentation about neoadjuvant radiation therapy in rectal cancer. I have one question because at the last ESMO, I attended a session about neoadjuvant radiation, and they were talking about the importance of timing rather than time. Okay, the classic way we do 5x5 fractions, the short course of radiation, is to do it, and 1 week later, patient should go to OR. But according to that presentation, they were talking about some of the studies which showed that if you delay surgery, like until 8 weeks or more, after the short course radiation, the rate of PCR will be much higher. So what's your comment about that?
Yeah, I mean, I totally agree with that. I mean, more and more, we have the timing is one of the factors to improve our complete response in both sides. We used to be shy from delaying the surgery from the short course because of that we are afraid of the acute or even toxicity at the time of the surgery. But we have reports in many centers that say that it's done and it's safely, and will give us even another advantage of downstaging, and a good number of patients, they will have a complete response.
Just a follow-up for Dr. Philip, a question about type of imaging that you use. Usually after radiation, and if you try to evaluate CRM, the sensitivity of the MRI go down. So I don't know how much you trust your images after the neoadjuvant treatment to make a decision.
Well, I'm not sure if I have a specific, number in terms of the specificity of the MRI itself. I mean, one of our colleagues from radiology was very interested in this, and he was reviewing our data. And I think that not yet he published his, but he was looking to correlate of the staging itself, not the CRM. Lucky for us, we didn't have any positive CRM in our cohort, but for the TNM itself, the number that he was giving us, it's close to 85%.
Okay, thank you very much, Doctor. Thank you very much. The next speaker is Dr. Gerald Prager. He will be speaking about the late-line treatments of MCRC and MGC today and tomorrow. Dr. Prager is an associate professor of oncology, Medical University of Vienna, Austria, and he is also the head of the gastrointestinal cancer program in the Department of the Medical University of Vienna. The floor is yours.
So thank you very much. I want to thank the organizers for inviting me. It's a big pleasure and honor to talk to you here at this wonderful symposium. So these are my disclosures. So it's good to see that within the last 10 years we did make a big step forward in having more and more patients fit enough to see a third-line treatment. While 10 years ago it was about 1 out of 4 of patients with metastatic colorectal cancer, we are now, can say, almost every second patient who starts a systemic treatment with metastatic colorectal cancer is fit enough and wants to have a third-line treatment. So we have to be aware that the first-line treatment is, at least from the statistical point of view, the most effective when it comes to response rates, but also for the progression-free survival time up to 1 year or 12 months. We know that by the second and third line, these numbers are cut by half, and we cannot expect to have a response in a third-line treatment setting. However, it's good to see, and these are data from the FIRE3 trial, which was a trial performed in Germany and Austria, that almost every second patient indeed was treated in a third-line setting. So while the progression-free survival time of the first line did not change over the last years, the overall survival time did. And this is most likely due to the fact that new therapeutic drugs were introduced into the clinic after oxaliplatin. The biologicals against angiogenesis like bevacizumab, aflibercept, regorafenib were introduced, and the anti-EGF receptor antibodies cetuximab and panitumumab. Recently, also a tyrosine kinase inhibitor in the third-line setting was approved, regorafenib, and we have now also in our hand a new anti-metabolic drug, which is trifluridine or TAS-102. And all these drugs have led to an increase in the prognosis of our patients by sequential treatment of our patients. So what kind of treatment options do we have in hand after a second line? So beyond second line, we have the trifluridine tipiracil. This is mainly based on the data of the prospective clinical phase 3 trial records with 800 patients randomized with a primary endpoint overall survival, which was clearly met when compared to best supportive care. We have regorafenib, which was approved based on the CORRECT trial, also clinical phase 3 trial, randomized against the best supportive care, and also improved the prognosis of the patients. However, we also have anti-EGF receptor drugs tested in the third-line setting like cetuximab and panitumumab, but we have to be aware that only patients with RAS wild type and only if they haven't been pre-treated with these drugs before are liable for this treatment. These were the patients included in this mentioned trial. So what is trifluridine tipiracil? It's not just another 5-FU. It acts differently than capecitabine, Tega-4 or 5-FU-based fluoropyrimidines. While the 5-FU mainly acts on the RNA level, the trifluridine tipiracil acts directly via DNA incorporation of the active compound trifluoromethyl deoxyuridine 5-triphosphate. And this is, has been shown in the preclinical setting that trifluridine tipiracil is still active in xenografts which are 5-FU resistant, while 5-FU itself, of course, was not active anymore. These are preclinical data. However, the activity after 5-FU failure has been tested in 3 randomized prospective clinical trials, 1 phase 2 and 2 phase 3 trials. All have shown an improvement in the prognosis of the patients. To go into detail in these 3 trials, the first trial, the J003 trial, was a randomized prospective phase 2 trial, and the other 2 trials, RECORS and the TERRA trial, were phase 3 trials. All trials in common was a 2-to-1 randomization design. All trials in common was the same dosage of the experimental drug, trifluridine tipiracil with 35 milligrams per square meter and with the same application regimen day 1 to 5 and 8 to 12. All trials in common was the control group, which was best supportive care alone. There are, however, minor differences. So in the phase 2 trial, also patients ECOG2 were allowed. In the TERRA trial, it was a trial performed in the Asian population. Primary endpoint in all trials was overall survival, secondary endpoint progression-free survival, time to treatment failure, disease control rate, and so on. You can see in this data that all 3 prospective randomized trials did met the primary endpoint in improving the overall survival significantly. The hazard ratio between 0.56 and 0.79 was in all 3 cases statistically significant superior when compared to best supportive care alone. Also, a secondary endpoint progression-free survival, quite similar in these 3 trials with hazard ratio between 0.41 and 0.48, statistically significant, and also very important, this was consistent across all pre-specified subgroups. When we compare the disease control rate, you also see very consistent data. About approximately 1 out of 2 patients have a benefit in terms of control of the disease, again, significantly higher than best supportive care alone. It was also clinically meaningful to see that the overall survival with a median of 7.1 was improved by the addition of trifluridine-tipiracil, and also the 12 months survival time was increased from 17 to 27%. So we see a long-term survivor in 1 out of 4 patients when treated with trifluridine-tipiracil. So this is, I think, also clinical meaningful improvement in the continuum of care of our patients with metastatic colorectal cancer. When we look at the Kaplan-Meier curves of the progression-free survival, we can see with a hazard ratio of 0.48, on the one hand that not every patient has a benefit of this treatment, but this we see in all third-line treatment settings. But those patients who do have a benefit, they do much better for a long time. And we see patients still have a benefit after 8 and 10 months. It is also important when we talk in the third-line setting about their performance status, and we can see that patients on treatment, they have a significantly prolonged time until deterioration of the performance status to ECOG 2+. So the patients have also clinical benefit in terms of sustaining the performance status when they are on treatment. If you look on the subgroup analysis, and I've highlighted here some subgroups like the performance status, trifluridine-tipiracil works independently of the performance status when they start treatment. It works independent whether it's rectal or colon cancer. It also works independent whether the patients have been pre-treated with 2, 3, or more 4 lines of treatment, independently whether they have been pre-treated with regorafenib or not. And this is, I think, the most important, it works after 5-FU failure because the patients all had been pre-treated with 5-FU in first and second line. It's very important when we talk about the third-line treatment that we talk about toxicity and tolerability. And you will see here in these curves, when we focus on the grade 3+ toxicity, there was not a significant difference when it comes to GI toxicity between the treatment group and the control group, which was placebo. However, we have to put the focus on hematotoxicity when we treat the patients with trifluridine-tipiracil. Grade 3+ toxicity, neutropenia, 38%. Also anemia and thrombocytopenia was higher than in the control group. On the other hand, we as medical oncologists are used to handle hematotoxicity, and we know this hematotoxicity also from combination chemotherapy in mCRC patients in first and second line. So on the other hand, there had been a post hoc analysis on patients who had neutropenia, grade 3+. It seems to be predictive, they did better in terms of an increase in median overall survival when compared to those patients who did not experience a neutropenia high grade. So what should we do if our patients experience hematotoxicity? It's different to an IV chemo that the nadir is, in the case of trifluridine-tipiracil treatment, on about day 21. So we treat the patients day 1 to 5, 8 to 12, and the nadir can be expected on day 21. However, on day 1 of the next cycle, if the neutrophils are below 1.5 and or the platelets below 75, then we just delay the next cycle by a week and retest the blood cell count before we start the next cycle of treatment. So not necessarily we have to do a dose reduction if we can manage the toxicity by dose delaying. So what should we do? That's the recommendation also by guidelines. We should use as many different agents as possible. This is reflected by the SEER database that patients who are exposed to multiple treatment options, they have a better prognosis. So we should consider patients for trifluridine if they lack IV treatment options. This is how it's in the label. The patients should be in a very good to fair performance status, so we also treat patients with ECOG performance status 2. This is also reflected by the prospective clinical phase 2 trial. However, the patient should be capable to understand the pill intake. It's a little bit different to other treatments. It's day 1 to 5 and 8 to 12, and so the patients need to be compliant. We should focus on timing the pill intake and the treatment breaks. We emphasize, at least for the first 1 or 2 cycles, to do a test, a blood cell count test on day 21, to get a feeling about the tumor, about the nadir of the blood cell count. And we should discuss with the patients abdominal pain and nausea and fatigue, although not high-grade toxicity can be expected. So if there is indeed high-grade hematotoxicity, we should rather consider dose delay. We should monitor the blood cell count on day 1 of every cycle, and dose reduction should be considered before serious side effects emerge. So this is the treatment schedule. So it's day 1 to 5 and day 8 to 12. The patients are taking their medication in the morning and the evening after they have eaten, within an hour with a glass of water after the meal. And we have experienced so far in our country some challenges when we prescribe the drug. Sometimes the pharmacy, although we're prescribing different boxes, they give only 1 box, or the lower milligram boxes, or the patients do not understand how they take the pill and they just take 1 pill of 1 box and that's it. So there are some mistakes in intake of the drug. So we should really emphasize in informing our patient, educating our patients when it comes to the pill intake. So in the sequence, we have for the very fit and fit patients, ECOG 0 and 1, 2 treatment options in third line. One is Lonsurf, the other is regorafenib. Both are level of evidence 1 options. We have heard wonderful presentations today about the option of re-challenging. However, the level of evidence is just much lower because the re-challenge studies presented so far are non-randomized studies with small patient numbers. So I would consider to do a re-challenge only if you really need tumor shrinkage in the late line setting or after failure of a level of evidence 1 medication, so in 4th or 5th line. For the ECOG 2, I think only Lonsurf is an option. I would not recommend regorafenib. This is also based on clinical experience, but also data from the Rebecca trial that the patients do not have a benefit of regorafenib. I think it's very consistent that patients ECOG 3+, best supportive care alone is a fair option for these patients. There are many interesting ongoing trials because the toxicity profile of trifluridine and tipiracil is very positive, meaning there are combination trials ongoing in colorectal cancer, combination with bevacizumab, combinations with oxaliplatin. There is also a combination with nivolumab. Phase 1 trial have been completed so far. Also in gastric cancer, we have seen data at the ESMO GI meeting in Barcelona this year, and the ESMO meeting in Munich, that this drug is also active in a 3rd line setting in gastric cancer patients. So as a summary from our experience, and we are using now this drug since almost 3 years, trifluridine tipiracil is an effective and good tolerable drug. The most common side effect we should put the focus on is neutropenia. As I mentioned, medical oncologists can handle this normally, so the tolerability is manageable and quality of life is maintained. Our patients like the drug very much because neutropenia they cannot feel. It's our job as doctors to have a focus on it, but this drug lacks hand-foot skin reaction. It lacks neuropathy like other drugs are doing. Experimental treatment concepts according to the molecular profile, and we have heard today very good examples, are very interesting and should be taken into consideration, especially if clinical trials are open and especially if the standard treatment options are not longer available because the patients eventually are progressing upon these treatment options. So they only should be applied if no standard treatment options are available. So thank you very much for your attention. I would be happy to take your questions.
Thank you very much. We have questions from the audience. Yes, please.
Thank you for the presentation. I was a little bit surprised by the rate of neutropenia that have been mentioned here. Do we know about the rate of febrile neutropenia, though?
Say it again.
The rate of febrile neutropenia. So what have been mentioned there is the rate of neutropenia.
Yeah.
What about febrile neutropenia? Was it mentioned in this trial?
I didn't get it right. The way febrile. Sorry, I didn't got it. No, I think it was in the very low one-digit number. So I don't have the exact number. Normally, it's very good handleable. The GCSF use is of course higher than in the control group. So what we are doing for patients as a secondary prophylaxis, we are using pegylated GCSF on day 13. So it's different to IV chemotherapy, where we give the pegylated on the next day. So here we give the trifluridine day 1 to 5 and 8 to 12, and in day 13 as a secondary prophylaxis, the patients receive the pegylated GCSF.
Another question with regard to when you mentioned the monitoring. Okay, you said that if the neutrophil count less than 1.5 will hold chemo until recovers be above 1.5. Don't you think this number is a little bit high for somebody who failed at least 2 or 3 lines of chemotherapy?
Yeah, this is how it's in the label, and this is how it was in the protocol of the clinical trials. But yeah, you're absolutely right. You can go lower. You can go. My limit is 1.0, but you know, if you're not so experienced with this drug, in the beginning, I would go for 1.5 to be on the safe side. Yes.
One last question.
A question about re-challenge of patients with colorectal cancer. You are a GI oncologist. We are GI oncologists. So if you're telling me that you need a strong phase 3 trial, I have to say that before 2013, none of your patients, 0 of your patients had third line, correct? You did not treat anybody before regorafenib became available, right?
Exactly. So what we know that re-challenging is an active option in certain patients. Yeah, we all do it when we have no other options available, and it's working. It's based also on some data, Optimox trial and so on, where they use the re-challenging concept. I absolutely agree, but we also know that the more time passes between early line of treatment and re-challenging, the higher the probability is that it works. So 50% of our patients after failure of trifluridine receive another line of treatment. And so I think re-challenging for those patients is a very good option. And we do it also in these patients, in these selected patients, and we all know that this might also work. Decision on an neither regorafenib nor trifluridine is a good option because they are stabilizing the disease. So I have, or I might prefer re-challenging in an individual case, but this is an exception, I would say, in a late line setting. So I think it's also my practice, what I'm doing. I have a first line, a second line, then I go to third line, and then I'm thinking about re-challenging of an earlier line.
Because you know they are superimposable. I mean, if you take the data, albeit phase 2 trials, okay, or phase 3 trials, for re-challenge, they are superimposable. The progression-free survival, the overall survival are probably a little bit better than either regorafenib or TAS-102 with a much higher response rate. So the fact that we have not done it does not mean that I think the large groups bear the consequences of that. To me, it's not fair in 2019 to come and present a data with an active drug and best supportive care. That's not the case in 2018, 2019.
I agree. We have to, however, we have to consider also toxicity. When we do re-challenging of, let's say, oxaliplatin, we are again provoking neuropathy, irinotecan, probably more GI toxicity. I think with trifluridine we have a good tolerable option, and in case we need to do re-challenging later on, we still can do it, yes, absolutely. But I agree with you. So was it a good step to use best supportive care as a control group? We can discuss this.
Okay, thank you, Dr. Prager, for the presentation. And I would like to thank all the audience and my colleagues, the moderators, for closing this session. And we come back after the break. Thank you very much.
because this is
Oh, that's the one that was
it's crazy because they have to have.
That's good to protect.
No, it's the hospital. That's why they have it. Let me see if it's working. No, تمام. نحطه. Okay. Computer.
Or open from here. Does he have two lecture?
No, and I already give the first one. This is my second lecture.
Okay.
So I'm gonna copy this.
Lecture mine.
معا.
Oh. But you are different here. You look like the other doctor. This doctor, what is his name?
Dr. Phil.
No. That's you?
Yeah, that's me.
Okay. I thought
Yeah, we look like.
yeah. So
لا مش مشكلة.
okay. I will just number it.
Okay, so حطه هون.
Just leave it here and I will
You put it over there.
yeah, okay.
Okay, تمام.
Just leave it. I will
ما تعمل هلا.
but I can use it without USB, right?
No, I
Okay,
can هلا.
it's
No,
not
I can.
protected.
Yeah, not protected. So I can. This is should exit.
Yeah.
Eject this one, right?
Thank you, doctor.
شكرا
Nice to
لك.
meet you.
pleasure meeting you. شكرا لك. Just double check
P16,
condition.
okay.
متأكد إنه كل شيء تمام.
Okay.
بس إنه sometimes. Okay.
إيه.
هناخذ دكتور احمد الشهري الان
إيه.
ونكمل مباشره ناخذ البريك خلاص.
اوكي لان انا سالت الدكتور احمد الشهري اذا محاضرته كانت قبل فهل it's gonna be switch ولا ما راح؟
لا
ايه اوكي
لكن حنكمل مباشره السيشن اللي بعد.
اوكي بس بتاكد دكتور من محاضرتك لان اعطاني الفلاش فبتاكد انها صح. لحظه بي 15.
ايش رايك اطفي عنك هذا؟
اوكي ثانك يو. Yeah, I will check it with you because I didn't find the one. I want to make sure. You can check. Okay.
should be fine. استنى هي التنفس يا.
Okay, thank you, doctor.
الظهر ثالث واحده رابعه.
ايه ايوه. Sorry, I found one but it's not the same one.
There.
This one?
So, no.
Oh,
There.
yeah.
Saudi Arabia, yes.
But it's not Arabic.
Yes,
But, yeah.
exactly.
Where are you from, doctor?
Please.
Okay. This one, right?
Yes, I will
Okay,
open it.
that's fine. I will open it just to make sure that it's okay.
Yes,
This one. Okay, doctor.
exactly. Excellent.
Thank you, doctor. Thanks a lot.
You're welcome.
Oh, you need the flash. Okay. Sorry. Thanks, doctor. I appreciate it.
You're welcome.
بسم الله الرحمن الرحيم. السلام عليكم. I think we're behind in time, so we need to go for the next session. And it will be the BMS Satellite Symposium. And I'm happy to chair or share maybe HCC practice with my brother and friend and colleague, Dr. Ahmed Al-Shahri. Dr. Ahmed will talk to us for about 20 minutes about systemic therapy in advanced hepatocellular carcinoma, mainly the role of immune therapy. Dr. Al-Shahri is a consultant medical oncologist and assistant professor in King Abdulaziz Medical City in Jeddah. Without further ado, Ahmed, stage is yours.
Assalamu alaikum wa rahmatullah. Sorry to force you to listen me again within a short period of time. I promise this will be more practical than the previous talk. So it's talking about the systemic therapy in hepatocellular carcinoma. Specifically, I'll talk about the role of immunotherapy in the second line setting. This is the outline of my talk. I'll talk about epidemiology of HCC in Saudi Arabia, treatment algorithm, clinical evidence in the first line, summary of the clinical evidence for the second line therapy. And I will focus on the immunotherapy when we come to the second line. So epidemiology in Saudi Arabia is number 6 when we consider all male and female cancer diagnosis. It's number 6 actually for both. But specifically talking about male is number 6, for female is number 9. So it's a more frequent. Just I want to bring to your attention, this is the Saudi Cancer Registry for 2014. Until that time, they only included HCC, pathologically proven HCC. And we know that many of our patients, liver cancer patients, they are diagnosed based on the radiological criteria. So the actual number, if we count the pathologically diagnosed and the radiologically diagnosed HCC, will be much higher than the numbers that we see on the screen right now. So the median age for male is around 68, like you can say 70. For female is around 65. Different etiologies in Saudi Arabia, including hepatitis B, hepatitis C, and NASH, the fatty liver. So if we continue the same treatment paradigm for hepatitis C virus, there will be an expected huge and acute rise of incidence of HCC in our country. The same for hepatitis B related HCC. There is a gradual, less steeping kind of increase in the HCC incidence in Saudi Arabia. And this is, as you can see, the green line at the bottom there represent the HCC related to NASH in our country. And all of these are based on some of the studies that have been published in our country. Most of the cases that are being diagnosed in our country are either regional or localized kind of HCC. And only like almost 1/4 of them, they have like distant metastasis. But this is not the only prognostic factor there. If you look at the liver function capacity, only 30% of patients, they present with preserved liver function, which means that 70% of our patients, they present at advanced stage with regard to liver function, and usually they present with Child-Pugh B or C, which will limit most of the systemic therapy options in these patients. This is a nice kind of graph from one of the publications done by one of our colleagues in King Faisal Specialist Hospital. As you can see, the difference in survival between two centers. One of them is King Faisal Specialist Hospital, Riyadh. The other one is Queen Elizabeth II, Atlantic Canada. And you can see there is a big difference with regard to survival of HCC patients between the Canadian Center and the King Faisal Specialist Hospital, which is one of the most powerful kind of centers of managing HCC in our country, which underscore the problem of the late diagnosis and the poor prognosis of our patients in our country here. So, most of us who are involved in the management of HCC are aware of this table. So the management algorithm of HCC depends on 3 major factors: the patient performance status, the liver function capacity, and the stage, the extent of disease, whether extrahepatic or intrahepatic metastasis. But the most important, I will focus on this part, are those people who have advanced disease, yet they have preserved liver function and good performance status. So if you have a patient who has a good performance status, ECOG 0 to 1, with a preserved like liver function, Child-Pugh A, they will be considered for systemic therapy. If they have poor performance or like poor liver function, usually these patients will be referred for best supportive care. What about the clinical evidence for first-line treatment? For a long time, more than a decade, sorafenib was the standard of care since it was published like more than 10 years ago, based on the benefit of sorafenib versus best supportive care with regard to overall survival and time to radiologic progression. The same kind of benefit was seen in Asian Pacific clinical trials. So we have 2 trials that proven that sorafenib is better than best supportive care with almost 2 to 3 months survival benefit, talking from east to west. After that, there had been many clinical trials trying to beat sorafenib in the first-line setting. All of them failed until the ASCO 2017, where we have seen that lenvatinib was non-inferior to sorafenib with regard to overall survival. So we have now another option in the first-line setting. So we have 3 clinical trials. We have 2 treatment options in the first line. One of them is sorafenib, the other one is lenvatinib. What about the second-line treatment? So if you consider second-line treatment in HCC patient, you have to properly select your patient to get the best outcome in these patients. So you have to choose those patients who have good performance status, preserve liver function, and you have to look at the side effect profile of these patients. We have several kind of treatment options that have been approved in the second-line setting. The group on your right, on your actually left, I'm sorry, is the anti-angiogenesis, and on your right would be the checkpoint inhibitors. So if we're gonna talk specifically about the second-line setting, these are the treatments that have been approved as anti-angiogenesis: regorafenib, cabozantinib, and ramucirumab. All of them were shown to be better than best supportive care after failure of sorafenib in the second-line setting. What about immunotherapy? Immunotherapy has a unique mechanism of action. This is a very interesting paper because it was published in May 1893, okay, before even this country was found on the ground, okay, and it was published by an orthopedic surgeon, as you can see, with a gorgeous mustache over there. And what they did there, they reported that injection of a killed bacteria into sites of sarcoma could lead to tumor shrinkage. So this has raised the initial kind of idea of the immune response as a mechanism to shrink the tumor. So what's the idea of having an immunotherapy? Okay, the classic paradigm of cancer treatment is to give the patient cytotoxic treatment that will affect the cancer cell immediately. While nowadays, we are giving the patient an immunotherapy that will activate his immune system, so the immune system will attack the cancer cell. So this is the bottom line of immunotherapy. As you can see from this graph, it's a full cycle, the immune cycle, as we said. If you can look at the step 1, where the cancer cells release antigens, these antigens will be recognized by the dendritic cells. The dendritic cells will release a lot of cytokines, which will activate T killer cells and cytotoxic cells, and this will lead to aggregation of T killer cells and infiltration of the tumor by these T lymphocytes, and this will lead to more destruction of the cancer cells, more release of antigens, more recognition of the antigens, and the cycle will go on and on and on. So this is the idea of the immunotherapy. However, it's not as simple as we think, as we know that we have a co-stimulatory signals, we know that cytokines can activate the immune system, and we have, on the other hand, co-inhibitory signals. So we have several mechanisms that can inhibit the immune response, so we'll avoid any kind of collateral damage that might happen from unwanted immune response. And the most common kind of inhibitory mechanisms are those related to what we call the checkpoints, PD1, PD-L1, and CTLA-4. And there have been several treatments that have been approved to break these checkpoints. One of them is the anti-PD-1, nivolumab, pembrolizumab, anti-PD-L1, atezolizumab, durvalumab, and CTLA-4 like ipilimumab. Immunotherapy have been used and have been approved in several tumor sites, as you can see, but our concern today is hepatocellular carcinoma. So let's talk about nivolumab in hepatocellular carcinoma. I'll focus my talk on the Checkmate 040 study. It's a bit of complex kind of study that included more than 620 patients, and there have been several cohorts and several arms. I'll focus on cohort 1 and 2 only, and I'll take it in more details as you can see. If we take cohort 1 and 2 from the previous slide, we had only 262 patients here, and they divided their patients in 2 categories: sorafenib experience, which means second line after failure of sorafenib, and sorafenib naive. And each of these groups are being divided into 3 categories: those non-infected, hepatitis C virus infection, and hepatitis B virus infection. The primary endpoint was safety and tolerability, and the objective response rate. Okay, so looking at the best overall response, you can see the response rate was somewhere between 19 to 20%, talking about those like in the second line or the first line, those who are sorafenib naive and those who experienced sorafenib before. If you look at this graph, you can see that the benefit was seen in all of the 3 cohorts that I spoke about: the uninfected, the hepatitis C, and hepatitis B virus. And the time to tumor response was in the range of 1.4 months to almost 2.8 months regarding those who failed sorafenib or those who had nivolumab as a first-line treatment. So if you have a patient on nivolumab, usually you're going to see this kind of response within 3 months. Okay, so usually if the patient progressed after, like within these 3 months, probably those are the patients who will not respond to immunotherapy. And the duration of response, as you can see, is really long for these patients. It's ranging from somewhere between 17 to 20 months by having nivolumab treatment, whether talking about second-line nivolumab after sorafenib or in the first-line setting. The response, as you can see, the depth of response, again, regardless of the underlying etiology, whether hepatitis C, hepatitis B, or uninfected, you can see there was a deep and sharp response in all of these 3 categories. What about overall survival? Remember, here we don't have a comparison arm, but you can see that the median overall survival for those who failed sorafenib in the first-line setting was in the range of 15.6 months. This is the median survival. If we take the survival rate at 12 months, it was like almost 58%, and it was almost 46% at 18 months. So this is a real kind of big, kind of number for those patients who failed sorafenib. All of these data are for those patients who failed sorafenib and have been treated with nivolumab in the second-line setting. With regard to side effects, nothing in particular to be mentioned here. The people who started this kind of trial were afraid at the beginning that patients might have a flare-up of acute hepatitis, which was not reported here actually, and most of the toxicity that have been mentioned mostly was comparable to all of the known immunotherapy side effects that have been reported in previous trials in different tumor sites. So we'll focus now on those who receive sorafenib in the first line as a those who receive nivolumab as a first line. So they are sorafenib naive. Again, you can see that the objective response rate was in the range of 25%, which is again a big number. And as you can see, the benefit was seen in those, regardless of the underlying etiology, hepatitis C or B, or those who are unaffected. And the time to tumor response was in the range of 2.7 months. Once again, the response is expected to be seen within 3 months. So the design of this study was to do CT scan every 2 months. Okay, so what I would advise from clinical practice point of view, probably to do like CT scan every 2 months for the first maybe 4 to 6 months till you assure stability of response of the disease. Then you can prolong the CT scan kind of interval to make it like 3 to 4 months afterwards. Okay, once again, the depth of the response was like evident regardless of the underlying cause. And as you can see, the overall survival was in the range of like 28.6 months, the median overall survival for those who received like nivolumab in the first line setting, which is really kind of an unheard of kind of benefit for those people who have been started systemic therapy for liver cancer. The side effects, again, nothing surprising here. Most of these side effects is matching whatever we know about immunotherapy toxicities from previous trials. Okay, what about biomarkers? Okay, they reported with regard to BDL1 positivity, whether it has, like, they use 1% as a cutoff point here to define the BDL1 positivity here. And as you can see, regardless of the BDL1 test, there was a benefit, whether BDL1 positive or BDL1 negative patients. And as you can see also, the change in the target lesion was quick and sharp, regardless of the BDL1 test or results. Even when we talk about the underlying etiology, hepatitis C or B viruses, the benefit was there regardless of the underlying etiology. And as you can see, the immunotherapy did not change the viral load related to the underlying viral hepatitis infection. So as you can see, with regard to the quality of life of these patients, like up to week 25, the patients did not report any acute drop in their quality of life, which means that this kind of treatment did not affect the quality of life of these patients, and they had, in general, good quality of life scores from baseline to week 25 at least. Okay, so as a summary of this clinical trial, as you can see, the safety profile, which was one of the primary endpoints of this study, was proven, and we didn't see any surprising toxicity from such a treatment, whether in the second line or the first line. Talking about the objective response rate, it was evident regardless of the underlying etiology, and there was a long survival benefit, whether in the first line or second line. And as you can see, the benefit was evident regardless of the underlying etiology and regardless of BDL1 positivity. So based on this study, the nivolumab got accelerated approval in the second line setting for HCC patients, pending the results of much bigger trial using nivolumab in the first line setting in comparison to sorafenib. This study has finished accrual of patients. We are eager, waiting for the results of this study, which might change the treatment paradigm for HCC if it proven that nivolumab is superior to sorafenib in the first line setting. We are expecting the whole paradigm of the HCC patients to be totally different than what we have presented today. But as a bottom line, those patients who failed sorafenib, nivolumab is a very effective treatment with a high response rate and a durable response rate ranging from 20 to 25%. And those patients, they had prolonged survival benefit because of this kind of long durability, and hopefully we'll have the results of the first line nivolumab in comparison to the standard of care, which is sorafenib. With that, I would conclude my study here.
Thank you very much, Ahmed. And thank you for being even less than your time. So that gives us some time for a couple of questions. And I'll start with one, Ahmed. So as you showed us that now we have multiple options in second line.
That's true.
Is there a way to select for patients from immune therapy? What's your preference? Is there a population said that you like immune therapy more than other second line, other options? So
it's a very tough question and a political question at the same time. Okay. So we have, as you mentioned, several options. We have the immunotherapy on one hand, we have the anti-angiogenesis on the other hand. The benefit that have been, we don't have a head-to-head comparison between all of these. And what we need to look at actually is the toxicity profile of these agents. Okay, we know that tyrosine kinase inhibitor, like for example regorafenib and cabozantinib, they have a specific kind of toxicity profile that probably some of our patients and some of us we don't like to see actually. And we have the ramucirumab, which is a monoclonal antibody. It has its own toxicity profile. And also the other problem, which is the availability of these treatments. I don't think, like most of the centers that we have in our country, most of these medications are not available. On the other hand, nivolumab actually is with regard to toxicity, as we mentioned, nothing major there. It's a very tolerable kind of treatment. And according to the preliminary data that we have from the Checkmate 040, it's a very effective treatment. Actually, myself, I have few patients nowadays on nivolumab, and one of them actually showed Like really, he crossed like now almost 7 months on nivolumab with no major toxicity with ongoing response. I mean, the tumor, inside the liver is regressing. So my experience will favor nivolumab. To be honest with you, I didn't use any of the anti-angiogenesis in the second line setting for HCC. And I'm not quite sure if my colleagues here would have a different experience with regard to the second line treatment in HCC patients.
At the end of the day, they are all approved and they have very good quality of evidence.
Yeah. For now, what I would advise all of my colleagues to wait for the first line study of nivolumab, because if this study comes back positive, this will change the whole paradigm of the HCC management. So whatever we have discussed today might not be valid in 6 months from now when the data will be presented.
I agree with you. We are seeing a learning curve that with time, we're seeing more evidence and which will give us more insight to guide us to select the best for our patients.
True.
If no further questions or comments, I would like to thank you very much, Dr. Ahmed,
thank you.
For this presentation. And I would like to call directly the moderators of the next sessions, Dr. Jamal Zikri, Dr. Taha Lawati, Dr. Osama Abu Ghazia, Dr. Shadi Khayyat.
Well, thank you very much for the introduction, Dr. Fahad. This is the second session of GI Oncology. We have an exciting 4 talks. The first presentation will be about combined modality management of esophageal cancer. Will be presented by Professor Dr. Philip Agub Philip. He is familiar with the setting in Saudi Arabia. He has visited us a number of times. So we welcome him to do his presentation. Thank you.
Thank you very much, Mr. Chairman. Again, glad to be here, privileged to be here. What I'd like to do next, in the next 18, 19 minutes is to talk about the combined approach in esophageal cancer. Just to make a couple of comments, I think in GI oncology, if there is a disease that requires a very close multimodality discussion and expertise, this is the disease, esophageal cancer, for a number of reasons. One of them is that it's really difficult to talk about standard of care in this disease. And the reason is there are different studies, many small studies. The populations are heterogeneous, different countries, different preponderance of the histology and standard of care. So it is something which you really have to work very close with the people you are collaborating with. Just very, very briefly, the global statistics, it's the 9th, some people call it the 8th most common cancer, and the 6th most common cancer, cause of cancer death. More men than women, and the median age, as many other cancers, is over 60. A point which is really very important is the fact that the vast majority are squamous cell. Although where I work, we see more of the adenocarcinomas, as you would expect. So there has been a shift in the proportion of patients. The curability has improved from the 5% many years ago to close to 20% in the Western world and China. You can see here that the incidence of the adenocarcinomas versus the squamous cells is really changing in a very dramatic way, which is interesting and partly explained by the smoking, which is being less and less, and that affects the squamous cell, and also by the reflux, the Barrett esophagus, which is increasing because of the increase in the body mass index of people in the westernized cultures. At this point in time, we still see the majority of the patients come to us more than the localization to the primary site. So they come to us either with regional involvement, with metastases in the lymph nodes, or patients coming to us with metastatic disease. And in fact, we see a fair number of patients who come to us with distant metastases. Usually it can happen in the peritoneum, in distant lymph nodes, or in the liver, for example. So still dealing with a disease that at the end of the day, there's a lot of micrometastases, and that's why a lot of these patients fail, where the micrometastases are within the regional lymph nodes or at distant sites. This is just to show you, this is a diagram, just to give you the feel for the T stage. I want to focus on this. And the T stage, if you have very early disease like TIS or T1A, those patients are closer to T1B. Those patients may be even treated by a very expert gastroenterologist who can do a local resection and save the patient the surgery. The surgery, the esophagectomy of this disease has a lot of comorbidities and even a mortality to it. So whatever you can do in a very localized disease, then it will be very helpful. The other thing is that there are patients who have more advanced disease like the T4. Those patients can be, even if they are localized, not surgical candidates because of the invasion of local structures, such as even cases like pericardium. And then the lymph node metastases are also very important. So when we see a patient, what are the major considerations when we see a new patient? The accurate staging is really important. Now, if you have someone who already has liver metastases on your CAT scan, it doesn't matter. I mean, the patient already has stage 4 disease, but those patients who have localized disease, we really have to map the disease, the T stage and the N stage accurately. The nutritional assessment, when I see patients and I'm working with a fellow or the resident, I tell them before you think of any chemotherapy and all these things, please focus on the nutritional needs of the patient. Sometimes patients who have more advanced disease will require the placement of a feeding tube. And also trying to get the diet maybe changed in a way that they can get more calories in because they cannot swallow well. Supportive care and also I call it rehabilitative care, but supportive care is very important. In my opinion, patients with esophageal cancer and other cancers do require the help of the supportive care team. And here I'm not talking about palliative care, which is preparing patients to hospice. And then the most important thing is that the treatment has to be personalized per the patient. The modalities that we're talking about, a single modality usually could be either endoscopic